Life Matters. My name is Brendan O'Connell. Well, we've been battling the whole euthanasia and physician-assisted suicide thing, and we thought we'd put it to bed a couple of years ago when we voted on it and won 51 to 49% in a come-from-behind victory for the pro-life movement. But it's reared its ugly head again, and we're going to speak with Dr. Bill Lawton today. And he was a professor, taught at the University of Iowa, was it?
Yes, sir. Yeah.
For about 40 years, internal medicine, and get his view. He's moved to Worcester County in Massachusetts to be close to his daughter and grandchildren, and he's taken up the banner and has testified or gone up to Beacon Hill to meet with legislators on this impending issue, which may come down this year. Would it come down, or next year? Or?
So it's before the legislature now. It's a 2-year cycle, so it probably won't be decided, but there'll be a lot of activity and discussion in 2017.
I see. Well, now tell us, you have a slideshow here. You wanted to hit some highlights. Shall we go into that and take a look at it?
That would be great. Just part of my passion for this is caring for patients with end-of-life issues for 50 years, and as I've mentioned to you, I'm a specialist in kidney diseases and internal medicine. So the issues of making a decision for dialysis, end of life, starting dialysis, the knowledge that you can actually stop this type of therapy if you want, has really been part of the bread and butter of my patient care. But if we go to the next slide, I think probably a good place to start is to just talk about not only what is physician-assisted suicide, and probably better termed doctor-prescribed suicide, but what's pushing it. And the next, just for some definitions, physician-assisted suicide occurs when a doctor helps a person take his or her own life by actually writing a prescription for lethal medication, and that allows the person to actually commit suicide. Euthanasia is very close to this, and it occurs when another person actually does the action with the intention of ending the life of a suffering patient. The next slide. So what are the concerns of our fellow Americans? Why is this an issue, and why does this keep coming up? And there are good reasons behind it. If we could go ahead, go forward one. So the biggest concern is fear.
Mm-hmm.
And fear of what? Fear of what? Next, the first fear that comes up is really fear of pain and suffering, loss of autonomy, being hooked to machines. And I've already mentioned that it's not new. This has been in place for decades, that patients can limit the amount of care they have at the end of life. And then the third big fear is you'll hear the proponents for this talk about, this is my life, my choice. And I'd like to examine these in just a little bit of detail.
Okay.
If we could go to the pain issue, a very real concern. Physicians caring for patients at any stage in their life want to alleviate suffering and be sure patients are as comfortable as possible. So today we have the best pain control in the history of the world, and no patient really should suffer. Next. And part of this has come through the dramatic increase of the specialization called palliative care medicine, a team headed by a physician specializing in pain control, but end-of-life issues are addressed by nurses, social workers, counselors, including spiritual counselors, psychologists, psychiatrists, to meet the needs of patients at the end. And anesthesiologists are an important part of this team as well. And the next. So this is interesting. As we know, the state of Oregon was the first to legalize physician-assisted suicide, and we have quite a bit of information. And the issue of pain, or even concern of pain, is not number 1 or 2 or 3 on the list, it's number 6. And even concern of pain is listed by 25%. These are real concerns, but it's not number 1. If we could go on with what, I also had a mentor, a wise mentor, tell me, Bill, when you're dealing with patients, just remember that you don't have to kill the patient to kill the pain. And if we can go on. So loss of autonomy, being hooked to machines, these are very real concerns as well. And if we proceed on here, this again is a fear that should be alleviated by our advancce directives, by the power of attorney for health care, by living wills.
Well, let me ask you, when I was out in California, I heard for the first time the word POLST, and here in Massachusetts they call it MOLST, a physician-ordered last surviving treatment or something?
Yes.
And they call it medical here instead of physician. Wasn't that set up by the Hemlock Society initially, the people involved with the Hemlock Society?
It has been, and there are dangers. This gives almost blanket coverage when a person, say, would go into the hospital at a certain point in time trying to predict what their wishes would be at the end of life. And so we are advising patients and families to not sign these because you don't know at X point in time what your wishes may be down the road. So there is great danger in these POLST, or as we call it in Massachusetts, MOLST.
Forms, okay.
Exactly, thank you. And then the loss of autonomy, I did address this concern that should be alleviated by our palliative care teams, which really address these end-of-life issues. If we can go forward. And then my life, my choice. So first, we need to keep in mind that legalizing physician-assisted suicide is really not about giving patients the right to die. Suicide is not illegal, as tragic as it is, but it's about giving physicians the right to kill, which goes against the 2,500 years of tradition in patient care. Let's examine this a little bit further. So this issue of choice is being thrust forward primarily people who are white, well-to-do, well-educated, well-insured. And if we give this choice to a small segment of society, it actually will limit choice for a much different and other segment of society. And what will happen, and we'll talk about this a little bit further, that this will be dangerous for who? People of color, people with disabilities, our elderly and institutionalized patients, and so a large segment will be in trouble. Absolutely. The poor are part and parcel of this, and I actually have a few things that kind of address that specifically in relation to the poor and people with disabilities and people of color. Thank you for the question. Yeah. If we could go ahead. Let's kind of look at that in a little more detail. So assisted suicide is not safe. Next. So this population is for our Commonwealth of Massachusetts. If we look, there are 6.5 million people in our state. About 80% are white. But look at the numbers of Hispanic or Latino folks living in our Commonwealth, or Black or African Americans. There are over 1 million people of color in our state, 15% of the population. And these are the people that will be most adversely affected. If we could go forward here. Now this slide is just a little bit busy, but if we could focus our attention, first of all, you can see the red arrows. And what is this slide trying to show? This is the U.S. poverty rate. Then there are 3 columns, as you can see. If we just look at the third column under each of those red areas. So what is this telling us? For individuals who are white, about 10% live in poverty. Look at African Americans, over 2.5 times the poverty rate. In our Hispanic population, again, 2.5 times that of white people. If we go to the next slide, and we look at Massachusetts, those were numbers for the United States in general. The number in poverty here in Massachusetts, 750,000. And look at this now in our Commonwealth by ethnicity. Again, the white population in poverty close to the U.S. average. But look at Native Americans, 18.5%. Look at African Americans, 22%, over twice. and Latinos are 3 times the rate. So what is the point of some of this? Well, first, this is not new information, or should not be new information, that our folks who are African American, our folks who are Latino, have a much higher rate of poverty. And then those who do live in poverty are disadvantaged when it comes to physician-assisted suicide. I'll come back to that point if I may.
Okay.
But if we can go ahead, we have unfortunately similar figures with those who are disabled. Next slide, please. So again, of our population in Massachusetts, another 770,000 people live with disabilities, almost 12%, very close to the almost 40 million people with disabilities in the country as a whole. And the next slide. This now links disabilities with poverty. And if you look at the 3 columns at the farthest right-hand side, people who are disabled, who live in poverty, look at the white bar. It's over 16%, 1.5 times people who are white without disabilities. But now, look at our black population, 3 times that, up at 36, more than 1/3 of the people. And our Latino population, near 30%. Again, twice the white population. So again, being disabled and being a minority is a tremendous disadvantage. If we go ahead, so now how do we, again, try to connect some of these pieces? Well, let's look at examples of individuals who have been poor and what this assisted suicide law means to them. We unfortunately have some of the longest data, as we've mentioned, from Oregon, and this is a patient, Barbara Wagner from Springfield, Oregon. And the next slide. 64-year-old woman, had lung cancer, had been in remission. The disease returned, would likely kill her. And her doctor wanted to give her an expensive new drug that he thought would help her. He prescribed it, but the Oregon health insurance plan, this is a government plan, this is Medicaid of Oregon, denied this expensive new drug that her doctor had prescribed. And instead, the Oregon health plan said, we will give you drugs for assisted suicide.
And how expensive were they?
At that time, $50.
$50 to kill yourself.
$50, yep. So for those who are poor, the insurance companies, government, this is incredible. If we could go back to that slide, clearly to their advantage to have assisted suicide much cheaper. There are other examples of individuals, again, unfortunately from Oregon. There's a gentleman by the name of Randy Stroop. I do have a picture of him as well. And he has a video on YouTube that's heart-rendering. He had prostate cancer. His doctor wanted to try a new drug. The drug was expensive. Without any call, without any discussion, thank you. He got a letter, and he reads this letter on the YouTube, and the letter said, you have been denied this treatment that your doctor wanted, but we'll pay for suicide medication. And out of the blue, a form letter from the government. So these are concerns with people who are poor and dependent on programs like this. If we go to the next example, so those were some that had happened a number of years ago. We now have California legislation, one of the most recently passed legalization of physician-assisted suicide, California, in the summer of '16. And about 2-3 months later, we have a mother of 4 children, Stephanie Parker, 33-year-old woman, doesn't have cancer, but she has a condition of the lungs and of the body called scleroderma, where lung tissue is turning into a fibrous material, scar-like tissue. She was told she'd have 3 years to live. It turned out she's still living 4 years later. Again, her doctor wanted to prescribe new medication, a different type of chemotherapy. Medical insurance in California refused. She called them. They said, we won't pay for this, but we will prescribe or pay for lethal medication. However, you will have a co-payment with your lethal drug. Do you know what it was? $1.20.
$1.50 to kill yourself
$1.20.
as your co-payment?
$1.20.
Oh, $1.20.
Yeah.
Wow.
So the point that we want to make here is, again, these are arbitrary or maybe not so arbitrary decisions, but are in the hands of the government, the hands of private insurance, denying coverage for individuals as well. And these are patients who want to live. These are patients who have been poor. And when we multiply this with those who are disabled, with folks of Latino or Hispanic origin, with African Americans, I find it difficult sometimes to express my concern in words. So, one other group of individuals and are those who are elderly. And why is this of concern? Well, first of all, there's an increasing problem with elder abuse. So 1 in 10 of every people over 60 has been a victim of elder abuse. And in Massachusetts alone, the numbers that are being reported to our Executive Office of Elder Affairs is increasing. 2015, the last that I could find figures, 25,000 cases were reported. They confirmed 7,000. There's been a 57% increase over 4 or 5 years of confirmed allegations and problems with elder abuse. And the reason...
And why is that? Is it that it's easy to report now, or they've set up a system to do elder abuse? Or is it just you think that's been in place for a while and that there really is much higher elder abuse?
And this is, again, a tragic chapter in what's going on in Massachusetts and indeed the country. There is evidence that the increasing elder abuse is being linked to our opioid epidemic on one hand, and on the other hand, it's also being related to the fact that more young people, college age and beyond, are having to move back home because of economic problems. So now you have people who are unfortunately addicted to opioids and drugs. They're moving back in the house. They see an elderly father. They see grandma there with the Social Security check coming in. And what shows, I think on the next slide, here we go, is what's kind of pushing this in part, and this is financial exploitation. I have on this slide the things that constitute elder abuse: physical abuse, emotional abuse. But one of the points with the financial exploitation, in the assisted suicide bill, a person has to request it of their physician. There is a 15-day waiting period, has to be then signed, and it requires 2 witnesses. This, I just cannot believe, that one of the witnesses can be an heir to the estate. So, you know, it doesn't take much imagination to see how the financial exploitation problems for the elderly not only are increasing, but elderly individuals are certainly at risk for this. Mm-hmm. If we could turn for a minute then just to the problems in society. If we go ahead. So we've talked about individuals. Many of our viewers are probably aware of Brittany Menard, a 29-year-old California woman who had a severe form of brain cancer. And this, first, the issue is tremendously emotional, the whole issue of physician-assisted suicide or doctor-prescribed suicide. And I don't want to minimize that. These are serious issues. Brittany, unfortunately, this was sensationalized in the media, including cover of People magazine. This was not available in California where she was living, so she moved to Oregon, and she died in November of 2014. And the next slide, actually I won't read all this in the interest of time, But the day before, if we just look at the bottom part in yellow, on October 31st, 2014, she said she would not kill herself and rethought the circumstances, saying, "I've decided it's not the right time." And the next day, she took her life.
But and wasn't there a YouTube video of her on October 31st
Yes.
saying that she didn't want to take her
Yes.
life?
Yes, yes.
So do you think she may have been coerced the next day?
It certainly raises, this was so highly publicized and sensationalized, we can only
I mean,
speculate.
she is the
We don't
poster
want to-
child for the whole
Unfortunately.
physician-assisted suicide movement.
Unfortunately, yep. And the day that she actually took her life, she actually went out for a walk with her husband and her dogs. From reports, she was being treated for a seizure disorder, but she was otherwise quite functional. But the next point I want to make with the whole issue, if we can go to the next slide, this is an issue that we don't hear a lot about. This is the danger of removing hope for a medical breakthrough. And the next slide. So remember now, she took her life November 2014. This is the cover of Time magazine 4 months later. On the cover, 2 women closing the cancer gap. And I have a little arrow to the woman on the left, Mary Ann Anselmo. She had the same tumor that Brittany did. She was being treated with a new form of therapy at Memorial Sloan Kettering in New York City. And as of the report on Time magazine, her tumor had not grown in a year. The last report I could find on Mary Ann Anselmo from the summer later on in that year, her cancer was, quote, gone.
Oh, that's fantastic.
Yes, so this doesn't mean there's a cure, but we have the next slide tells the story of an ex-Marine living in our neighboring state of New York. This gentleman's name is J.J. Hansen. 2014, same year as Brittany Menard. He was living life, doing well, had a seizure disorder, investigated, and he had brain cancer also. He chose to live, and he again was treated with an experimental drug and was in remission as of report May 2016, 2 years after the diagnosis. And the next slide shows his family. He was doing everything he could, see his wife, his cute little boy. And again, I won't go through all the details on this, but I just received a report from last month that now his brain cancer has recurred. He had been in remission. He's been alive 3 years after the doctor said he had 2 to 4 months to live. And some of his statements, I think, are so important for our society. He does not see assisted suicide as a choice that affects the individual. Its influence on others should keep it illegal. Having the option to die will dishearten severely ill patients, especially those who feel they're a burden to their families and are experiencing depression. This is a time they need the most support and most encouragement.
Mm-hmm. And how do you feel that your profession, the medical profession, has been compromised by the whole physician-assisted suicide? I mean, were you, as Dr. Jefferson told me, I got into the medical profession to be a healer, not an executioner.
Absolutely, and I would agree with that 100%. I think that there clearly are differences of opinion, there clearly are concerns for the end-of-life care, and for example, in the state of Oregon, there are some physicians who will agree to this and are actually on a special list by Compassion and Choices, the former Hemlock Society. So the safeguards in some of the legislation just are not there.
I see. Can I ask you, as we're coming to a close of the show,
Yes.
The Compassion and Choices of the Hemlock Society is taking a different approach now. What is that approach that they're taking with the legislature? And isn't it a doctor that is the catalyst to all this?
The Compassion and Choices actually has targeted Massachusetts as the #1 state that they want to see the bill passed. And they are actually mounting, for the first time in any state, a four-pronged approach. So one is the doctor that you mentioned, who has prostate cancer and chooses or has stated that he thinks it's his right to be able to have the lethal medication. In addition, this is now the 7th time in the state legislature since 1995, so they keep coming back. The third is, again, trying to work through the Massachusetts Medical Society to have them go neutral. They've been adamantly against this and subscribe to the ethics of the American Medical Association. Physician-assisted suicide is just incompatible with a physician's role as healer. And where a medical society has been neutralized, Colorado, Vermont, then this opposition is no longer there, and the states will legalize the suicide. And the last, if all of these don't come to pass in 2017, it's going to go back on the ballot in 2018 after being defeated.
In what, 2012?
2012.
2012,
yes.
my goodness gracious.
And I don't know if we have time for one last slide or
go
not.
ahead.
If we could go for the very last slide, which is a wonderful positive statement. This is by a woman who actually suffered a diving accident in Chesapeake Bay 50 years ago, paralyzed from the neck down, tried to commit suicide. She was so depressed. Her suicide was treated. Her depression was treated, and she did not achieve suicide. 50 years later, she has some tremendous programs to treat people with disabilities, including our veterans who have been wounded. And this closing thought, it should not be the state's responsibility to help despairing people kill themselves. Let's channel more effort into improving therapies and hospice. Let's lift people out of depression through compassionate support, family assistance, help, strengthen the cords of compassion that have characterized our nation for many decades. We must do all we can to protect, defend, and preserve every life.
Well, Dr. Lawton, thank you so much for being on the show today. Really appreciate you coming all the way from central Massachusetts.
Yes, well, I appreciate this opportunity. Thank you so much.
And we hope you found today's show to be unique, informative, content-rich, truthful, and thought-provoking. Thanks for watching. I'm Brendan O'Connell, your friend for life.